transverse aortic constriction to induce pressure overload. I would like to start with a brief introduction to prenatal and postnatal development of the heart. As you know, cardiomyocytes are the main component and contractile unit of the heart. During prenatal development and shortly until after birth, the heart grows by cardiomyocyte proliferation. But cardiomyocytes withdraw from the cell cycle and terminally differentiate within the first week of life. And after that, the heart grows by physiological hypertrophy, characterized by cardiomyocytes growth and endomitosis, leading to binucleation of most of the cardiomyocytes. Mitosis also occurs without karyokinesis, resulting in polyploidy of half of the cardiomyocytes. Physiological hypertrophy enables the heart to meet the increased circulatory demand of the growing body. It also happens during pregnancy or regular exercise training. That's why it is not a cardiac disease, but it enhances cardiac contraction, perfusion, and metabolism. When the adult heart is exposed to myocardial infarction due to occlusion of a coronary artery, it leads to acute loss of myocardial cells, especially cardiomyocytes. Owing to lack of regeneration capacity of adult heart, the heart goes through cardiac remodeling to compensate for this non-contractile part of the heart. Therefore, it leads to dilation, change of the left ventricle, and heart failure. And that is why myocardial infarction and cardiovascular disease are the leading cause of death worldwide. On the other hand, when neonatal mice are exposed to different types of surgery, for example, LAD ligation, cryo-injury, or apex resection, they are able to fully regenerate the heart by enhancing cardiomyocyte proliferation. But this capacity is lost 7 days after birth, when cardiomyocytes withdraw from the cell cycle. Cardiac pressure overload is another detrimental stimulus that triggers pathological cardiac remodeling. Transverse aortic constriction or TAC surgery has been widely used to induce pathological hypertrophy or heart failure in adult mice. But in human, it occurs in patients with aortic stenosis or chronic arterial hypertension. It induces myocardial damage, severe cardiac dysfunction, which is not reversible. Although physiological hypertrophy is characterized by normal organization of cardiac structure, normal or enhanced cardiac function, pathological hypertrophy is mainly regulates fetal genes and cardiomyocytes hypertrophy. It leads to cardiomyocytes death, fibrosis, and cardiac dysfunction. To decipher whether regenerative mechanism in neonatal mice could promote compensation of pressure overload, I have established a neonatal model of transverse aortic constriction at postnatal day 1 and 7. Within this webinar, I'm going to show you how to perform a neonatal model of transverse aortic constriction to induce pressure overload in neonatal mice. Also, I'm going to show you how to confirm the surgery using Doppler Flow Velocity measurement and how to assess the cardiac function using echocardiography. Furthermore, I will show you what is the outcome of surgery when it is performed in postnatal day 1 or day 7. What are the materials you would need? Of course, you need your mice. I have established and optimized this procedure using male and female CD1 mice at postnatal day 1 and 7. Mice within the first 24 hours after birth are considered 1-day-old mice. And I have also successfully performed this surgery in 1-day-old transgenic mice with a mixed background SV129 and CD1 background. So I speculate that this protocol should be applicable in any mouse line or strain. And the surgery tools and materials that you need for this surgery are polyamide sterile synthetic and non-absorbable suture to constrict the aorta. It is size 10:0. You need an absorbable suture for suturing the ribs and skin. A blunt 33G needle to constrict the aorta, and this surgery is optimized and the results are obtained using this size of needle. And you need to keep in mind that using less or more gauge size will directly influence the degree of pressure overload induced and might influence the outcome of surgery as well as mortality. And you will also need microneedle holders, scissor, and a pair of forceps that are very fine but not sharp. Furthermore, a few Q-tips might come in handy, and also a Petri dish filled with ice and water, as well as isoflurane and anesthesia box for anesthetizing the mice. And also surgical tape you need. A heating lamp is needed for recovery of the mice. Ice pad is used as operating table, and you need a microscope with enough external or internal light source. You will need a Doppler Flow Velocity measurement device, ultrasound device, as well as ultrasound gel. All the animal experiments must be conducted according to your institutional or governmental rules and regulations. So make sure that before you perform any experiments on animal, your animal protocol is accepted by appropriate authorities. Okay, now what are the steps in this nTAC surgery? You need to relocate half of the pups from the mother's cage to a container or a warm pad, and then cover the pups with a mother's cage bedding so that they feel comfortable, and keep the mother's cage away from the pups. And to anesthetize the pups, so you need to put in isoflurane box and contains isoflurane and oxygen, followed by placing the mice on ice water bath. So you need to pay attention that the mice should not be in direct contact with ice, although they have a high tolerance to hypothermia, but direct contact with ice can lead to frostbite. So make sure that there is ice water bath, and you need to check the mice for PAR reflection, and the duration of this hypothermia or anesthesia might be variable when you are using different mouse strains, but I would suggest that 2 to 3 minutes for P1 mice and 3 to 4 minutes for P7 mice should be enough, but you have to make sure and confirm that. But prolongation of hypothermia can also lead to mortality. For surgery, you need your ice pad, and you need to take it out prior to the surgery, maybe 1 hour before, to reduce the coldness, and also cover the ice pad with a thick layer of plastic before you place and fix the mice on top of it. But this ice pad can also prevent excessive blood loss during the surgery. And so fix your mice with tapes, with surgical tapes. And as you can see, the mice from the 1 to 7, they don't need intubation. And under the microscope, make a skin incision and open the thorax directly at the sternum, a little bit to the left side, and make 2 small cuts until the second rib. And make sure that you are not exceeding the second rib, because this might damage the heart. Under microscope, the first thing that you will see is the thymus. Thymus is covering the aortic arch, and it consists of 2 lobes. So you need to find the middle part of the thymus and gently with your fine forceps pull them apart from each other. Do not remove the thymus, as this might lead to rupturing the aorta. When you pull the thymus aside, then you should be able to clearly see the aortic arch. If you are not able to see it, so readjust the microscope, add extra lighting source, or clean the area using a Q-tip. Because at this step, you need to insert the needle from 10 to 0 suture underneath the aortic arch. And you need to be careful not to damage the aorta or the heart. When your needle passed the aortic arch, pull it gently without damaging the aorta until the suture is underneath the aortic arch. Then place the needle, the 33G needle, parallel and on top of the transverse aorta, and make 3 knots, each at different directions, but make sure that it's tight enough. And at this step, after ligating, so you need to gently remove the needle without rupturing the aorta. Then you can use your absorbable suture to suture the ribs. Make sure that you are suturing between the ribs, the muscle between the ribs, and not damaging the ribs, because this might also be harmful and lead to mortality. Then you can use the same absorbable suture to suture the skin and underlying muscle, and make sure that the sutures that you are making are very small and tidy and not recognizable by the mother, which leads to cannibalism. And at this step, do not use the skin adhesive, because the mother will recognize the uneven part of the skin and will try to remove it, and this leads also to mortality. The whole procedure of the surgery should not take more than 10 minutes per pop. And the same procedure is applicable for 7-day-old mice, and also for sham surgery, you use the same procedure except ligating the aorta. For recovery, place the pops in front of a heating lamp, and you will recognize the recovery by spontaneous breathing and circulation. And this should not take more than 2 to 3 minutes. And when the pops have recovered, then you need to put them further away from the heating lamp to prevent burning the skin, but keep them warm either further away from the lamp or on a heating plate. Then you can place them back when you are done with the half of the pops, so you can place them or replace them with the other half of the mice, the pops in the mother's cage, and mix them with the bedding, which has traces of urine. This reduces the cannibalization rate. And before putting the mice in the mother's cage, make sure that they are warm and active. And you need to administer the painkiller according to your accepted animal protocol, which might be variable in different regions or countries. And also you need to check the pops 3 days post-surgery. Usually cannibalism happens within the first day after surgery, but you need to control them, that whether they are able to drink milk and the body temperature is okay, or they are accepted by the mother. If it is not the case, you might think of providing a foster mother. And ensure that the mother have access to free water and food with enough nutritional value. What are the troubles that you might face? Your mouse might be bleeding during the surgery, and of course, this might lead to mortality. But what are the causes? So it is probably that you have damaged the heart, the ribs, or the aorta. As I mentioned, when you are cutting the ribs, do not go further than second rib, as you might damage the heart. And when you are inserting the suture, make sure you are not damaging the heart. Or when you are ligating or you are closing the ribs, also, if you damage the ribs, this might lead to bleeding, as well as when you are inserting the needle underneath the aorta. And it can be that the surgery is successful, but the mouse doesn't wake up. What could be the problem? The problem is that you might probably took more than 10 minutes to do the surgery. You have to practice the surgery in order to be fast enough for them to be able to recover. And your cannibalization rate might be too high. So different mouse or different strains of mice have different rates of cannibalism. For example, black 6 mice are not really good in taking care of the pups. So you have to get to know your strain of mice. And also, according to my experience, younger and unexperienced mothers are less likely to raise their pups after surgery. So you might need to think of foster mother. And also you might you have to pay attention that, as I mentioned, the sutures are clean and tidy and very small and not recognizable by the mother. And what if the surgery works and the mice wake up? So before you jump of happiness that your surgery worked, you need to confirm the surgery's success with Doppler flow velocity measurements. For this purpose, you need Doppler flow velocity device, consists of Doppler probe. I'm using a 20 megahertz probe and the Doppler transceiver, digitizer, and a laptop showing your Doppler workstation, a heating plate, and pre-warmed ultrasound gel. The success and degree of induced pressure overload can be monitored using measuring flow velocity of right carotid artery versus left carotid artery. When you successfully measure the flow velocity here, you will be able to see the flow velocity in peaks in your workstation. So how to measure this flow velocity after surgery? You need to fix the mice again the same way as you did during surgery, but on the heating plate, and apply generous amount of gel on the neck area, and place your probe on the right as well as the left side of the trachea so that you can see the peaks. You can adjust the probe in order to see the peaks, and if the surgery is successful, you are able to see higher peaks or higher flow velocity in the right compared to the left carotid artery. These flow velocity or peaks are easily measurable using the same Doppler program. And this ratio will be equal to 1 in the sham mice, but more than 1 when the surgery is successful. Doppler flow velocity is not only essential to prove the success of surgery, but also it can help you to provide evidence that you have induced the same degree of pressure overload in different lines, genotypes, ages, or different types of mice that you have in your experiments. And I have to add that this Doppler flow velocity measurement can be applied immediately after surgery in P7 mice, but it's better to let the mice in P1, after P1 surgery, to heal the injury for 2 days, at least 2 days. And what could be the problems you might face at this stage? You might not see any signal. So the probe that you are using is 20 megahertz, and it has a minimum gate depth of 2 millimeters. So you need to make sure that you apply generous amount of gel in order to provide enough distance between the probe and the artery, because the skin in neonatal mice is very thin and the carotid arteries are very superficial. So it should not touch the skin, or it should not be very far away from the skin. You need to find the proper distance that the probe can measure the flow velocity. And you might see some peaks, but they don't look like the ones I showed. So it means that you are in a proper distance, but probably not in a proper location. So you need to get familiarized with the anatomy and where to measure the right and left carotid artery. And it can be that the flow velocity of the right common carotid artery versus left is not more than 1 that we expected. It can be that it's equal to 1 or less than 1. This means that the surgery was not successful and could have different reasons. It can be that your knot was too loose, or it has been opened, or it is located in a wrong place, and you need to further confirm this. But before I continue and show you how to confirm this, I would like to hand it back to Sam for audience poll, and I'll take it back and show you for further confirmation of the surgery.
Thank you, Mona. Yes, to give Mona a quick break to catch her breath, perhaps get a glass of water, we're going to launch our middle poll. This poll asks, will you be attending an in-person conference this year? So as we know, all conferences have pretty much gone virtual for the past year, but some are planning to open at the end of the year. And we're curious, the attendees, who is perhaps planning on attending an in-person conference this year. I know most of it does depend on COVID, so that probably will be the most popular choice. But if you would like to, you can specify which ones you are interested in the chat window below. I'll give you guys just a few more seconds to make your selections. Due to COVID, everything has been changing, and we're just curious where things are heading. All right, it seems like the majority has answered, and the majority does depend on what happens with COVID-19. So thank you guys all for participating, and I will bring back Mona to finish the rest of her presentation.
Thank you, Sam. Yeah, so you might need to see what has happened to your suture and also your constriction that you have made. So you need to visualize the aortic arch. And this you can use, for this purpose, you can use ultrasound device. You can place the pump in the pre-warmed heating plate of the ultrasound device, and you need to use a proper ultrasound device with appropriate transducer, which has a central transmission of 50 megahertz. And then in this position, you can visualize your aortic arch and whether your suture is still there or is it located in a proper place. And if it is in a appropriate place, so it might be that it is too loose to induce pressure overload. You can also use ultrasound device to check the cardiac function at different time points of your surgery. For example, you can use B mode to visualize and record a few long and short axis view of the heart. And you can also analyze the data and make sure that you are using consecutive systolic and diastolic areas and at least 3 heartbeats per mouse. And after you are done, you can just record the videos and continue. Just remove the gel and gently remove the tapes and place the pups back to the mother's cage. So what are the important parameters that you need or it's good to measure using echocardiography? It's good to measure ejection fraction, and this is represented in a percentage, and it shows how much blood the left ventricle pumps out with each contraction. You can also measure fractional shortening. This is the reduction of the length of the end diastolic diameter that occurs by the end of systole. So this is also a fraction that shows the contractility of the heart. You can measure cardiac output, which is very much heart rate dependent. And because it is the volume of blood that is pumped from the heart per minute. And it's also good to measure left ventricular and diastolic area, showing whether you have dilated heart or not. And wall thickness, which is usually measured from the short axis, can help you to measure if you have hypertrophy in the heart or not. At the end of the study, when you take the hearts out, you can or you will be able to visualize that you have bigger hearts after surgery, but you need to measure heart weight to body weight ratio and to investigate the hypertrophy. It's also good to measure lung weight to body weight ratio, as the increase in the lung weight to body weight ratio is a sign of pulmonary congestion and could provide evidence that the heart is failing, but you need to confirm it definitely with echocardiography. And you can embed the hearts in OCT or in paraffin for further histological analysis, for example, fibrosis, using serous red staining, or checking the structure of the heart using H&E staining, or you can further perform different immunofluorescence stainings, for example, using antibodies against cardiomyocytes, for example, troponin T, troponin I, or proliferation markers such as Ki67, PH3, or Aura B. You can check angiogenesis with IB4 or CD31 antibodies, or you can check cardiomyocytes hypertrophy by measuring cardiomyocyte cross-sectional area using WGA staining. So what is the outcome of the surgery? I have performed the surgery from the first day until 7 days, so for induced for 7 days. And as you can see, I have shown that I have successfully induced pressure overload, which was measured 2 days after surgery. And 7 days after surgery, the hearts were heavier than sham hearts, but there was no difference in the lung weight to body weight ratio. As it was confirmed by echocardiography, 7 days of pressure overload in 1-day-old mice did not change the cardiac function, left ventricular and diastolic area, but it increased wall thickness. To further assess if pressure overload can induce fibrosis, I stained the hearts with serous red, and I saw that 7 days of pressure overload in 1-day-old mice does not induce fibrosis in the heart. But further staining showed that this pressure induces angiogenesis as well as cardiomyocyte proliferation, and at some degree also cardiomyocyte cross-sectional area. But my aim was to compare whether there is a difference in regeneration and non-regeneration phase. That is why I continued the surgery from first day till 14th day. And I also compared it with surgery starting from non-regeneration phase, day 7, until day 14. As you can see, flow velocity revealed a similar degree of left ventricular pressure overload 7 days after induction of pressure overload in day 1 mice, as you can see here, and immediately after surgery in day 7 mice. And also at the end of the study, both groups were exposed to the same degree of pressure overload. So it means that from day 7 to day 14, they were exposed to similar degree of pressure overload. And heart weight to body weight ratio increased in both groups, but interestingly, lung weight to body weight ratio increased only in the non-regeneration phase, although they were exposed to only 7 days of pressure overload. This was further confirmed using echocardiography that even 7 days of pressure overload starting from non-regeneration phase reduces cardiac function or ejection fraction in neonatal mice, but not 2 weeks starting from 1 day. And wall thickness was increased in this group, as well as left ventricular and diastolic area. To see the underlying reason of this reduction in ejection fraction in non-regeneration phase, I stained the hearts with serous red staining. And as you can see, 7 days of pressure overload increased fibrosis in the heart, but not 2 weeks of pressure overload in regenerative phase. Further immunostaining showed that pressure overload in regeneration phase increases angiogenesis as well as cardiomyocyte proliferation. But in non-regenerative phase, pressure overload increases cardiomyocytes cross-sectional area, which is hypertrophy. So in this publication, I have further showed that how inhibition of cardiomyocyte proliferation or angiogenesis leads to maladaptive response, even if it is induced from first day. So it means that cardiomyocyte proliferation and angiogenesis are the hallmark of this adaptive response. I wanted to continue the study since the neonatal mice in non-regenerative phase were exposed only to 7 days of pressure overload. I wanted to investigate whether with prolongation of pressure overload, they can develop compensatory mechanism or not. That's why I continued from day 7 to day 21, 2 weeks of pressure overload in non-regeneration phase. And I also continued from regeneration phase till 21, so for 3 weeks. As you can see, there is no difference in the pressure overload at the end of the study, and heart rate to body weight increased, which was expected in both groups. But still, we had heavier long weight to body weight ratio only in the non-regeneration phase, which was also confirmed with echocardiography showing reduced ejection fraction in the heart of neonatal mice when they were exposed to pressure overload in the non-regeneration phase. And I didn't see any left ventricular end diastolic area change, but the wall thickness was increased in regeneration phase. And further serious red staining showed that, again, we have a significant amount of fibrosis in the heart when only pressure overload is induced from 7 days. And further analysis and immunostaining showed the same pattern, that we have increased capillary density in only in regenerative phase, but they could not increase angiogenesis, and cardiomyocyte proliferation is still higher when pressure overload is induced in day 1 mice. But again, the cardiomyocytes hypertrophied in non-regenerative phase, like what we see in adult mice. To understand the molecular mechanism of this adaptive and also maladaptive response, I sequenced the hearts at 14 days after inducing pressure overload in 1-day-old mice and 7 days after inducing in 7-day-old mice. I've seen that a lot of pro-regenerative genes are upregulated in regenerative phase, such as immune response, positive regulation of proliferation, angiogenesis, muscle contraction, wound healing, and axonogenesis, and a lot of non-regenerative genes, such as the negative regulation of cell proliferation and positive regulation of apoptosis, are upregulated in non-regenerative phase. I further confirmed that I have more nerve covered area in when pressure overload is induced in regenerative phase, and there are more immune cells in the heart. Further studies showed that, which is published in this publication, that most of the upregulated genes in regenerative phase are direct target of GATA4, which is a very important transcription factor in the heart. And the transcriptomic profiling in conjunction with my nTAC experiments in cardiomyocytes GATA4 knockout mice revealed GATA4 as a master regulator of this adaptive response. This was in concordance with my previous publication showing that loss of regeneration capacity of mice at day 7 is associated with downregulation of GATA4 in the heart. So I would like to conclude that 1-day-old mice in the presence of GATA4, they have the ability to adapt to pressure overload by inducing cardiomyocytes proliferation, angiogenesis, and inervation in the heart, which leads to preserved ejection fraction and no fibrosis. This is called an adaptive response. But when pressure overload is induced in 7-day-old mice in the absence of GATA4 or in GATA4 knockout mice, and pressure overload induces cardiomyocyte hypertrophy, which is leading to high mortality, reduced ejection fraction, and fibrosis. And this response is called maladaptive response. Understanding the innate regenerative mechanism that enables the neonatal heart to adapt to pressure overload could be useful to develop new therapeutic strategies to treat patients or prevent pressure overload triggered cardiac diseases in the future. For more details about the surgery and procedures, you can refer to my Nature protocol, and you can also here see a video of the surgery. And if you are more interested to see the outcome of the surgery, the cellular and molecular mechanism, role of cardiomyocytes, proliferation and angiogenesis, or role of GATA4 in this adaptive mechanism, you can refer to my JCI Insight paper. And if you are more interested to know more about GATA4 and its role in regeneration ability of neonatal mice, you can refer to my embomolecular medicine paper. I would like to thank at the end Professor Heinecke, who was my PhD advisor, and I spent a few years also as a postdoctoral researcher at his lab, which allowed me to establish this surgery. And I would like to thank Professor Fleischmann, who gave me an amazing opportunity to establish my group at his institute and supports me to further continue this field. And I would like to thank you for your attention. I'll be giving it back to Sam, and I'll be happy to take further questions.
Thank you, Mona, for that wonderful presentation. As Mona mentioned, we will begin the Q&A, so I am going to encourage everyone to click on the Q&A button below and ask questions throughout this Q&A portion. Okay, Mona, Dr. Mona, we got plenty of questions so far, so I'll begin with the first one. First question is, how do I get started and prepare to learn that surgery you mentioned? What are the first steps?
Yeah, so familiarize yourself with the anatomy first, and then maybe use dead animals, dead adult mice to learn where the aorta is located and how can you really constrict it. If you have the permission, even it's a good idea to perform the surgery on adult mice and then start using neonatal mice.
That's a good idea. Another question that's come in is, what animal strains are the best to use for this purpose for the neonatal mice model, and why would you recommend those animal strains?
I would recommend CD1 mice because they have a larger litter size, they have better nursing behavior and larger pups. So it makes life much easier. And if you are or you have to use another animals or mouse strains, for example, Black 6, it's good to have CD1 mice as a foster mother to help that to reduce the cannibalization rate.
That's a great point on the cannibalization. It's something that people have to be aware of and account for. Based a little bit on that, the next question I was asked is, what is the mortality rate that you find in your surgeries and after?
In neonatal tag model, like in adults, the mortality rate is 10 to 20%. But in neonatal, we have to consider that there might be a lot of cannibalization going on. So you need to, and this rate of cannibalism might be different in different strains. So for this reason, I cannot give any percentage for cannibalism, but you can reduce it with the things that I mentioned, for example, using CD1 or taking care of the pups or generating less stress. And this can be really reduced to 0%.
Well, that's great to hear. Another question that was asked is what are the differences between the nTAC surgery and adult TAC surgery?
Actually, the general principles are the same. So you are constricting the aorta, but you need to pay attention that for neonatal mice, you need microsurgery skills and you need to operate under the microscope. And you have to be, most importantly, you have to be very fast. And adult mice, you need to anesthetize them in another way. They have different anesthetic and analgesic techniques, but they need to be intubated, but then you have more time to perform the surgery. And of course, the needle size you are using is different and it's just bigger. That's it.
Interesting things to keep note of, depending on the surgery, adult or neonatal. A couple more questions have been coming in, so I encourage everyone to continue to ask. Dr. Danan has asked, do you perform this surgery on the mice strain or the animal strain C57?
No, unfortunately, I haven't yet.
Oh, that's fine. Another question is how do you explain, or how to explain the protective role of P1 surgery compared to P7 surgery? And a follow-up is, does this surgery affect cardiac stem cell? I don't know if you have any idea or some.
So what is the protective effect or what is the protective mechanism? As I mentioned, so in neonatal mice in regenerative phase, they increase cardiomyocytes numbers, not the size of the cardiomyocytes. In non-regenerative phase, they just hypertrophied and this is not good and they die, the cardiomyocytes die. But neonatal mice, they make a bigger heart by increasing or proliferating. So we have at the end, we have a bigger heart, probably with more cardiomyocytes, which is stronger to pump against this constriction.
Okay, interestingly enough, another question is asked, what is the combined expected mortality considering all the potential issues? So going back to the mortality of this surgery.
Yeah, so if the mice is, so if you take care of all the conditions and measurements that you can do to reduce cannibalism, so, and your mice is experienced and it's not young, and you take care of all, I have reduced it to 0. So you can reduce it to 0, but it can be that I mean, if it is a lot, then you need to reduce it by like using older mother or experienced mother, CD1 mother. So in this case, you can really reduce it to 0%.
It sounds like it's a combination of, like you mentioned, a lot of things. The strain of the mice,
Yes.
older, more veteran
Yes.
mother,
Mm-hmm.
and then careful practice,
Yeah.
making sure the sutures and everything. So it's a combination of everything. So I imagine one would expect, if you don't follow everything, you can expect some mortality.
Yeah.
A question about the Doppler signals, Mona. Due to the size of the neonatal mice, is there any risk to mix Doppler signals from the subclavian arteries with the carotid ones?
You need to know how the peaks look like, and so I did not have this problem, but you can check the flow velocity and the peaks, and I would guess that the more this right and left carotid arteries are the what you can clearly measure. So I think the other ones are more difficult to measure. It to me it appeared like this, that the first signal that you get probably is the right one if it looks right.
Interesting. Based on the surgery, there's a question on the surgery practice. Dr. Pills asks, how do you avoid harming the tissue, heart, aorta, trachea, etc., when using sharp needles, 10 -0 to insert the suture? Do you blunt them?
No, absolutely not. But that's why I mentioned that you need to clearly see the aortic arch. And when you see it, you will clearly see that there is a distance between the heart and the aorta. And you need to, when you are inserting the needle out, you need to go between this space. It is little, but you will see it. It is white, and you need to come out in this space. Otherwise, you will damage the heart. And when you are inserting also, you will see where the aortic arch is starting and when it's ending. That's why make sure that you can clearly see where the aortic arch is located.
Right, that would make sense. Dr. Zaradnikova asks about proliferation. So the question is, the cardiac myocytes differentiate in mice after birth, and she believes that they are able to proliferate until day 3. So did you think about looking at the cellular structure to see if the proliferation window is longer after neonatal TAC?
Yeah, of course. So the time points that I looked were 14 days and even 21 days, and I had significantly more proliferating cardiomyocytes in this case. So I could prolong the proliferation rate after inducing pressure overload.
Okay, of course that makes sense. Another question's asked, do you have any tips or tricks in using the Doppler signal for acquiring consistent signals?
I think you need to just play around with it and adjust it and learn where you need to hold it and where you need to locate it. So, and also you can consult with expert people if the signal you are getting is right. And I think it just needs practice and you need to learn it.
That makes sense. Uh, we have a few questions that are coming in based on anesthesia and painkillers, and I just would like to mention that that could depend on where your protocols depend on your country, depending on what is expected. So I don't know if that would be. We can answer those questions individually. We have a few more minutes to answer any other questions. If anyone else has any few questions, we have about 5 more minutes. Is there anything, Dr. Malek Mohammadi, you'd like to expand on or touch upon?
No, I think I mentioned everything. Nothing special comes to
Oh,
my mind.
okay, sounds good then. Then if anyone else has any questions, any further questions, we can definitely connect you with Dr. Mona or answer them individually. But actually, a question just came in. Dr. Fahad Ahmed asked you, Dr. Mona, how would you like to proceed with this research in the future?
So I have a few projects and I would like to learn more about the mechanism involved in this adaptive response. My aim is to understand or really review the mechanism. That's why I established my group, and this is my aim, to clearly understand this adaptive response to help or come up with a therapeutic strategy in the future.
And that'd be fantastic. That'd be great. Okay, so that really does take us to the end of this presentation. And I'd like to thank you again, Dr. Malek Mohammadi, for your research and for your establishing this neonatal nTAC protocol. I'd like to thank everyone for joining us today, and we are going to wrap things up. So as mentioned at the start of the webinar, we will answer any outstanding questions privately with anyone waiting for a response, and we will also publish a written transcript of all question and answers. Again, I'd like to thank Mona for her interesting, incredibly informative presentation, and I hope that everyone walks away satisfied that we met your learning objectives. Feel free to check out Cintiqa.com/webinars for our upcoming webinars. If you are interested in similar research using Doppler system echocardiography to acquire signals, we will be hosting similar webinars in the coming weeks. So feel free to check our website and learn more. Thanks again for everyone taking time out of your day to attend our session. We look forward to seeing you at a future Cintiqa instrumentation event. Have a great day, everyone.